Hey everyone, let's talk a little bit more about first MTPJ arthrosis, arthritis. We're talking hallux rigidus, hallux limitus here. I've put a few of our gold stickers onto some of the nerve pathways and sort of the typical protocol that I'd be looking at. But initially, let's start with the positioning of the patient. I'll typically have my patient sitting there and I'll rotate the foot out a little bit, or maybe just even plantar a touch, just so I can get a really good understanding and be able to look exactly where we're getting the pain. Now, of course, I'm going to really feel around for where their max pain is, and typically I'm going to find really right within that first intermetatarsal space, sometimes at the joint line and maybe just a little bit distal to the joint, deep in that first space, potentially right over the top, as well as sort of in that medial, just distal to that dorsomedial bump and just before that dorsomedial bump as well. And of course, we've got our Joplin's neuroma in this area, and this is the exact same protocol that I'd be using for that as well. And so, then I'm starting to trace back up, and we typically have a few of these areas just in this spot here, as well as then as we're coming up that, our superficial perineal nerve, where we're wanting to really make sure that we're hitting there, as well as that medial dorsocutaneous. Sometimes I will do straight over the joint. In this type of injection, we're not wanting to go into the joint, but do consider whether a corticosteroid injection may be a more appropriate option. When we're looking at this, patients get a really good outcome immediately. Very rarely does it, is there a delay in getting the response, but often they'll be sort of, they'll just feel really thick and heavy. They won't be able to get that full dorsiflexion, and so of course it's going to feel a little bit more comfortable, but people typically do respond quite well. It's typically well tolerated. People don't get too much pain, and like a lot of my other injections, I'll just put a little bit of hyperfix over the top there just to keep it steady and stem any of that bleeding that's occurring as well. Again, I do use a bit of laser power, laser therapy there just before I go in, and do consider whether you want some sort of an orthotic to either increase that joint range of motion or stop it completely. I do get my patients doing sort of some big toe joint rehab exercises, whether that's resistance or literally just distract and dorsiflexion, plantar flexion. So that gives you a little bit of a further idea of what we're looking at. Now, again, we are wanting to do, 2 or 3 levels above where we're talking. Very commonly though, I'll go, up to wherever I need. Typically, it's never above that mid shin, because people, and these ones just above the ankle, that's usually sort of our more tender spot. And then we come down maybe one at the ankle and 1 or 2 sort of in this area. And otherwise people, have pretty good pain tolerance there. And it's not too bad. But hopefully this gives you a little bit more information on that first MTPJ arthrosis. Cheers.